Okay, well, hi everybody. And you know me, I'm Nancy Klimas, the Director of Institute for Neuroimmune Medicine. But I'm going to introduce what I consider a good friend, Jaime Seltzer. Jaime is the Scientific Director of ME Action. It's a healthcare nonprofit advocacy organization that's dedicated to infection-associated chronic illnesses. She's responsible for the project management and clinical and research associated projects, and fostering communication between research scientists, clinicians, and people with infection-associated illness. She's the author of the ME Actions Research Review, consolidating 200 plus references, with each section peer-reviewed by PhDs in relevant subjects. She's also the editor and consultant for Jen Brea's TED Talk on healthcare equality and groundbreaking Sundance award-winning health documentary, Unrest. I appeared in Unrest.
Yes.
Yes, she made me find that shirt I wore the first time 2 years later for a second thing. Anyway, Jaime received her Bachelor of Science in Plant Science from Rutgers, and later received her Master's of Science degree in Clinical Alternative Medicine from Maryland's University of Integrative Health. She's a researcher at Stanford, working with the Stanford Genome Technology Center and Snyder Lab. Additionally, she has experience as an assistant professor of organic chemistry at Maryland University of Integrative Health. Jaime is a Time 100 Health honoree. That's quite a distinction. An award recognition that the 100 most influential people in health globally. Think about that. That's pretty impressive. She was recognized largely for her research and clinical education work on infection-associated chronic diseases, especially myalgic encephalomyelopathy, chronic fatigue syndrome, ME/CFS, and long COVID. Her areas of focus are patient-led research and clinical care initiatives, medical education, and large-scale epidemiologic studies with rich patient input. That is the intro. So that say it all, Jaime. Take it away.
Quite an introduction. The only thing I'd add is that I think apart from the Time 100 thing, what I am most known for right now is a collaboration with Mayo Clinic Rochester, where I co-authored the diagnostic and treatment algorithm, and Ask Mayo Expert produced a concise clinical review with Mayo Clinic clinicians. And that has a 1 credit CME, and it is still available. So people can take it and get your credits that you need to stay a doctor. And yeah, we're hoping to replicate that work with other clinical institutions, because we find that from an advocacy point of view, when people participate in the clinical education initiatives themselves, then there's more institutional buy-in. So rather than solely spread the Mayo work, which we've tried to do, we hope to replicate similar work with other large-scale institutions. So welcome to everybody who's here. Thank you so much for having me. I'm going to go ahead and share my screen. Give me just a second to get this set up, and then we'll launch into it. Once again, we're definitely encouraging questions here. So as you think of questions, please place them in the chat or jot them down to yourself, and let us begin. So this is about Recover TLC, which is an NIH-led initiative on drug development, particularly in long COVID. So Recover is the original NIH-funded program to address long COVID, but Recover TLC is a little different. First of all, it's led now by NIAID, whereas the rest of Recover was led by cardiopulmonary. Invitees to this 3-day conference included long COVID researchers, healthcare providers, people affected by long COVID and other infection-associated chronic illnesses, advocacy organizations, and federal policymakers. So the goals of the meeting were to try to consolidate what had been learned from Recover, discuss the structure and governance of this new initiative, Recover TLC, cover some of the current research, and help plan future NIH long COVID clinical trials. And the last of these, I think, is one of the most important things, not just for long COVID, but for the infection-associated chronic illness landscape. So each day sort of was divided up by theme or topic. The first day was looking back at what we've learned about long COVID. There were a lot of presenters providing their lived experience. There were clinicians, and there was a summary of activities that were still ongoing, some of which we will discuss. The second day was discussing the path forward, including which interventions we ought to prioritize, study design, endpoints, and to some degree the pathology of the disease, because that linked very closely into the biological underpinning or reasoning for which interventions to prioritize. Then day 3 was basically outlining next steps. And there was a bit of a focus on drug development that day, as well as we had people from FDA on the panel talking about the best steps forward for drug approval in these diseases. And I'm making a note to myself too for something to tell you. Okay. So one of the most important things about the conference was how many different people with lived experience ended up sharing their point of view at some point over the course of the conference. This is not everybody who spoke or shared information. This is just a handful and chosen completely at random. So one of the things that I wanted to highlight was a quote by Angela, who's in our upper right-hand corner. She is a long COVID patient and was one of the original founders of, one of the original members of PLRC, Patient-Led Research Collaborative, which studies long COVID. She said, patients who had ME/CFS for decades guided me to the right specialists at the right time, but many aren't accepting patients anymore, so I cannot guide friends to the same care. And then a little bit later in the talk, she said that she was done with patient representation and was asking NIH to share power. This is a general theme of the patient input in Recover TLC, so I wanted to take a moment to discuss it. Generally speaking, as somebody who lives with this disease but also has a research background, we have actual inclusion in research and clinical care initiatives, and we do have tokenization as well. So someone might form a patient committee for a study. If it's tokenization, oftentimes that committee is attended by one able-bodied person whose job is to carry news of what the patients think back to the actual research team. And organizations like Patient-Led Research Collaborative, and I would say ME Action as well, have been pushing for more inclusion. One of the stumbles of the original Recover was that patients were not deeply embedded in the research process from the very beginning of research, when you're coming up with hypotheses that you think are reasonable to investigate, or your research question, all the way through to dissemination and translation. If you're not including patients at every step, then you can end up with a research question or a hypothesis that's not really sensible in light of patient experience. And that's when you end up with potentially a combative atmosphere with patient inclusion, because the patient is going to tell you your research design or your clinical initiative does not make sense. However, if people with lived experience are treated as partners from the very beginning or as part of the research team, the results can be much more useful. My general impression is that people consider patient inclusion an ethical imperative rather than something that improves the quality of their research, and it should certainly be seen as both of those things. So other themes that people focused on, who were people with lived experience, were the inclusion of people who had infection-associated chronic illnesses before COVID. And in particular, one of the things that I said on my panel was that if we only approve drugs for people with long COVID, and we do not have comparator groups that have, say, ME/CFS pre-COVID as one of the groups, then when we have future pathogens, new infections, it will certainly be argued by insurance companies and so on that these drugs are not applicable to these new patients. We do have to accept that infection-associated chronic conditions can be triggered by multiple different infections, as well as other immune perturbations that are not infections. So we need to think of not just the patients who have been sick forever, not just the patients of today, but the patients of tomorrow. People also were talking about more BIPOC inclusion, which is, this is more of a Canadian and less of an American phrase, so Black, Indigenous, and people of color, in both patient representation and in terms of inclusion for subjects for studies, for drug trials. People also talked about the low accessibility of clinical care, the high cost of clinical care, and several people talked about being dismissed or stigmatized as part of their experience as a patient. There were conversations also about masking, physically masking, and about accessibility of the NIH campus. A personal story, which if you guys follow me on social media, you may have already heard. Please bear with me if you've heard it before. I unfortunately left a medication back at my hotel and had to escape the NIH campus and return. And even though my hotel was a 5-minute drive away from the campus, it took me an hour and a half to go and come back. So people were mentioning other aspects of the lack of accessibility of the campus in general, and also the general lack of masking. This is definitely a conference where I would say that more people were masking than is average for a gathering, in part because it had high disability representation, in part because there are people who understand that infection can cause long-term symptoms, and in part because these are COVID conscious and COVID educated people who were aware that we were in the middle of a surge in that particular part of the country during the conference. But at the same time, I would say that maybe 3/5 of people were unmasked. And that was something that JD pointed out as making the meeting less accessible for disabled people or inaccessible for disabled people. So that's something that is going to be an ongoing concern for people who have disabilities, but it really should be a concern for everybody. A colleague reached out to me after the conference and apologized for not being masked. And I think, and he pointed out as well, that there is this idea that if you are able-bodied, you probably already have some kind of protection against having a long-term chronic illness. But there are many people who have developed long COVID after their second or third or fifth infection. So simply because you caught COVID once and were okay afterwards, it's really no guarantee that that will always forever be true. So that's something to consider in terms of making your spaces accessible to disabled people, especially conferences where a lot of people are packed together in a very small space. And if possible, when you have gatherings that are more social, having them outside is a really good strategy. Okay, so we covered a lot of the science over the course of Recover TLC. I think that probably the most important aspects of what I heard were that there is a great deal of focus on viral persistence, and people are considering that. However, when drugs were being investigated in a preliminary way for long COVID, a lot of what looked more promising was immunomodulators. Only time will tell, and reasonably designed studies which that turns out to be true. The reason that I have the conclusions up here, which is from Dr. Jeannie Marazzo, is that it's going to be a very good summary of everything that was discussed during the conference, and we will be able to elaborate on some of these as we go through. So Dr. Marazzo included a summary that she had been writing over the course of the conference, which personally very impressive. I actually asked NIH if she had had most of it already, and they told me no, she had been taking notes and she had been constructing her conclusions as she was listening to people. And that definitively showed in the contents of her conclusions. So, as we discussed, patient community involvement was critical in all aspects of planning clinical trials, from the intervention, selection, trial design, conduct, and so on and so forth. I thought it was interesting that they concluded discussions can be robust and respectful at the same time. I agreed that this is the case, and that's not because being polite is the thing that we should prioritize. It's because as long as people who disagree both have the same central ethical principles at the heart of what they're arguing, then it's very easy to argue data points and understand that when it comes down to the most important aspects, we're all on the same page. Leadership should be accountable and transparent about the process. This was something that the original Recover team stumbled on a little bit. And I have to say that the likely reason for this is that institutions like NIAID are very used to dealing with patients as advocates. And I'm not sure that, and I should say, just in case you need the context, ME/CFS patients have been under NIAID and NINDS, and AIDS HIV has been under NIAID. So there's a lot of understanding of how to negotiate power with advocates and patients, researchers and clinicians. There's an understanding of that gained through experience that I'm not sure cardiopulmonary fully understood. It's important to move forward quickly without sacrificing scientific rigor, and we can use the data we've gathered from Recover in order to be more successful. She mentioned ensuring meaningful and real participation of patients and advocates from now on, which we really certainly do hope will be the case. A lot of what she discussed was having more open communication. So a recurring annual meeting where we're going to discuss drug trials and their progress, as well as monthly updates in order to let the community know where we are in the process of various clinical trials. And we also had conversations about committees for drug approval, for reviewing grants, and definitely the implication was that there would be more people with lived experience on these committees, as well as people from the pre-long COVID infection-associated chronic illness world. Okay. All right. So in terms of selection of clinical trials, they were discussing making shorter study cycles in order to get the word out there faster. FDA officials were present and they discussed creating relevant endpoints that can support regulatory decisions. One of the stumbling blocks that drug companies and researchers have had is that it is very challenging to understand how to conduct a study when you don't know what success looks like. So unless you have endpoints of, we expect this fatigue scale to change by this percentage, or we expect the 6-minute walk test will show improvement, it's very challenging to justify the enormous expenditure for drug approval unless you know what FDA will accept in terms of endpoints. They wanted to emphasize conducting larger efficacy trials, but simultaneously exploratory studies involving many interventions with small groups. The hope is that these smaller trials will allow for people to choose drugs, choose a bunch of different drugs, and then continue the ones that are showing promise. And also there was an emphasis on the pediatric and adolescent population and ensuring that they would be able to have interventions and that they would not be forgotten in clinical care. there were conversations about how is it that we're going to actually dig down to the true pathology of long COVID. Recover did amass a large biorepository, but it's very challenging for researchers to access that biorepository. And hopefully that there are going to be easier paths to that moving forward. And I thought that this was interesting too. From the patient perspective, they were talking about there's a burden of specimen collection. It's one thing to have your blood drawn. It's quite another thing to have cerebrospinal fluid samples being collected. A lot is being asked of the patient population. And they were also talking about how you need to establish multidisciplinary groups when you're considering how pathology presents in this disease and how these biospecimens might be used. We've already talked a little bit about this because I was talking about the suggestions that people with lived experience had made, but it's important to emphasize that these are NIH's conclusions and I have barely reworded them. They recognize that it is a lot of work to organize. It's a lot of work to attend these meetings. And they also mentioned that the pandemic itself and the way that it was handled has resulted in some distrust from patients and from laypersons in general. And that part of their goal is to rebuild trust through authentic engagement. And that they mentioned an opaque top-down approach does not build trust or willingness to work together. And I remember that Jeannie Marazzo said at this point, as we have learned, an acknowledgement of the fact that Recover in the past was a bit too top-down. One of the patient advocates who was part of the people with lived experience on committees had mentioned that they had not seen, for instance, the exercise trial protocol until it was already finalized. So that kind of thing obviously erodes trust between NIH and the community. Providers are still under-resourced to give evidence-based and comprehensive care, which is one of the things that we're definitely pushing for at ME Action. And I know other nonprofits are pushing for better evidence-based care as well. We hope that we're going to have a community engagement group that's part of Recover TLC that's different from just the folks who are part of the Recover community engagement group. And I know that unlike the original Recover, where people with infection-associated chronic conditions before long COVID were not invited, I know that people in those groups will be invited this time around. And I was surprised to hear that they were interested in talking about treatment guidelines. I think it's very essential. It's not normally NIH's purview, but I suppose it's something that they can prod for. And they also were talking about quite concrete ways to support people with lived experience and younger researchers, including a community scholars program, mentorship programs, and sponsorship to attend these meetings. So from my point of view, these are the major takeaways that I had as a result of this conference. First of all, I think that there's very little that's more important than data standards and endpoints. Nancy and I started the meeting kind of talking about this and how efforts had been made in the past to develop endpoints for ME/CFS and that they're still quite vague. So we need that for long COVID and we need that for other infection-associated chronic conditions. And FDA and NIH and stakeholder representatives need to participate in the effort to do this. I really do think, and I said this at the meeting, that it's very important that we ensure that whatever instruments we use are capable of capturing variability in symptom presentation. One of the ways that it's possible to do this is by asking the same patient to fill out the same questionnaire on a very good day and a very bad day for them. if we see a difference, then at least there is the potential that that instrument can capture variability in this disease. And for that individual patient, we now have their normal range. So it's going to be possible to tell if they, as an individual, have improved over the course of a clinical trial. On a broader scale, we can do something similar with large groups of patients and ensure that we're actually capturing their variability as a patient group, as well as individual to individual comparisons. I do think that that's important because I've seen that the validation process for different diagnostic instruments is a little hand-wavy sometimes. For those of you who might be less familiar, when I say a diagnostic instrument or an endpoint, I mean any on-paper instrument or activity like a 6-minute walk test or a 2-day cardiopulmonary exercise test that you might measure in order to determine whether the patient or the subject in this case has gotten better or worse or not really shifted very much over the course of a clinical trial. So all of these things I think need to be we need to apply great focus here. And I think that this is a really good place for advocacy because we can't simply use the most popular instruments. They may not be effective. It's also the case that in this disease, the severe patients are extraordinarily severe, and they tend to fall off the lower end of function for many different functional capacity instruments. And their symptom presentation tends to fall off the high end in terms of determining how much they're suffering from a particular symptom. So we need to be sure that the range of that instrument is capable of capturing whether a mild or moderate patient improves and whether a severe patient improves. And that's very important if we're going to determine which drugs are actually most effective in these populations. We also have to find a way to measure changes in PEM presentation, which I don't think we have. Although people talked about developing one, but that's not there yet. In terms of NIH, Recover TLC has now created, and it's just opened a few days ago, a portal that will allow people to suggest drugs or interventions to trial for long COVID. As one of our advocacy actions, ME Action will be opening up a suggestion form, and people will be able to say which drugs they would most like to see as an intervention and why. But of course, even within our advocacy asks, we're also going to be encouraging individuals to submit if they should choose to do so. As far as inclusivity, this is a very broad topic, but there are several reasons why I think it's really important right now. At the conference, we saw people who were awarded money for the original Recover. We saw some people who have been in infectious disease research or clinical care or advocacy for decades. And we kind of saw that those two worlds merging for what felt like the first time. That's very promising. And it was explicitly stated that the goal of Recover TLC is to use the best of the new research and the most promising new researchers and integrate that world with the ME/CFS world that NIAID and NINDS has been familiar with for decades. There's also a distinctive thrust in terms of incorporating the experience of people who live with these diseases and people who research them, and a little bit of focus on the crossover. It was also really good to hear such emphasis on pediatric populations, on BIPOC individuals and their healthcare, and ensuring that they're included as subjects in research. So the fact that inclusivity in multiple different ways was being stressed, including Marasso at one point saying, we can't hold the meeting here next time because this is too disability inaccessible, was really a hopeful turn, I feel. So the last thing I'll say is there are obstacles. Obviously, the original Recover researchers as a group still seem as though they're not very engaged with the community, but this conference definitely highlighted many people who are. Accessibility and masking is still a huge issue. And of course, the albatross around Recover's neck is the exercise trial and the games to improve cognitive function. Patients are still understandably very put off by trials that attempt to say that if only you were thinking correctly, or if only you were moving, exercising properly, you would no longer be a sick person. And I'd be happy to go into the history of that for anybody interested, but I think a lot of us are in on that, so I will pass over that for now. Thank you very much. I am Jaime Seltzer. I'm Jaime at meaction.net. I am Exceed Her Grasp 1 on Blue Sky and Twitter, as in a woman's reach should exceed her grasp, else what's a heaven for? If you have any questions, I would love to hear them. If you have any input or anything you would like to ask me that I didn't talk about, because this was 3 days of conference, y'all, then I would be happy to hear. Thank you so much.
Thank you, Jaime. That was really lovely. Can you spend a moment, and because a lot of these people really are much more like laboratory and don't really understand perhaps how much work is actually being done by patient-driven research. Specifically, it would be really neat if you talked about how rapidly responsive patient research was to teach us what is long COVID and how it was presenting, and even how some people were starting to judge treatment efforts, things that
That
work.
is a wonderful, going to be some wonderful context, I think. It's a really good question. So I would say that arguably ME Action and I were among the first to recognize that, recognize in a public way, that SARS-CoV-2 was going to lead to an epidemic of infection-associated chronic illness. And even before long COVID was called long COVID, we were producing materials in anticipation of new patients. That includes the pacing guide. Pacing is the activity management strategy most recommended for people who experience post-exertional malaise. So we knew that a lot of people would be told by their doctors and their family and their friends and their bosses that you just have to get back on the horse and push yourself through, no matter how much your symptoms are flaring or how much you're suffering, and you'll just eventually work your way up to feeling better. So we wrote the pacing guide, pacing is about alternating activity and rest and ensuring that you are not so active that you flare your symptoms. And then the patient-led research collaborative and body politic were looking for information about this because they were originally advocacy organizations that were not long COVID focused. Body politic was. And they found us because we were out there in the world saying this is going to be happening. And were able to, Hannah Davis mentioned, who is one of the co-founders of Patient Led, that the 2019 research review that was very quickly mentioned in my bio was one of the first things she used to start understanding long COVID. And I applied for but did not receive an NIH grant in order to compare long COVID, ME/CFS, POTS, HEDS, and MCAS symptoms. And this was in 2020 that I first submitted that grant. And we did the research anyway. I can't announce anything yet, but there's a collaboration on the horizon that will allow a lot of data to come out of that project very quickly. So because we're small, we're very agile, and we're able to make things move much faster, I think, than other organizations. A patient-led group also was contracted by a grantor in order to judge relatively large-sized grants and get that funding out to researchers very quickly. So we end up serving as researchers, people who can reach the community and ask and answer questions very quickly, peer reviewers who have specialized knowledge that can determine whether research is going to be helpful or harmful very quickly. And so I think that all of that came into play. One of the most interesting papers that came out early in long COVID was in the Lancet from Patient-Led Research Collaborative. And that paper has been much cited and much discussed. The collaboration with Mayo Clinic Rochester that I did last year produced a concise clinical review, as I mentioned, and the way that it's traveled is extraordinary. Even before we launched a campaign to try and ensure that it was seen by a great number of people, its altmetric score was through the roof. And that's because patients recognized their disease when it was described by somebody who had that experience. It resonated with them. They wanted to share it further. For those of you who are familiar with altmetric, it has a score well over 1,000. I haven't checked it in a while, which would make it probably one of the most looked at papers that year. Does that answer the question?
Yeah, no, that's really impressive. I think what I was trying to say, because some people on the on this meeting are really well informed, and some people probably haven't been that exposed to patient-led or patient-integrated efforts in research. So if I were to first say that there's two different spaces in general, we're doing research. One is clinical interventions, which has been your focus, is clinical presentation intervention. But actually, patient, I'm not going to say input because it's not enough. It's like patient partnering
Yes.
in the basic sciences, in biomarker discovery, and in the modeling work is also very useful and gives us much, let's just say we're spending millions of dollars of federal dollars. We're spending all of our careers, our effort, our passions, our day-to-day existence doing all this work. Of course, we're motivated to having it be successful in a way that truly helps people. I mean, that is all of our motivation. It's not, how many papers did you write this month?
Well, we hope not. There are definitely people out there who that is their motivation, but
But I
that's
do
probably not the people in this
not on
room.
this screen. I can
Yes.
absolutely guarantee you that
Yes.
this group is, and these people, this university has been a good landing place for passionate people trying to do the kind of work that actually results in people improving. And that started in our clinic, and there's some history for some of the people on the screen probably don't remember this, but those of us been here the longest do. We originally, our space we were in was in a temporary space until our beautiful new building opened. And to get to your computational modeling office or your basic science laboratory office or anything else in our clinic, you had to walk through the patient waiting room. It was extremely meaningful to the people who don't get the privileges we do. The clinicians get to see our patients every day and hear them say, thank you for the work you do. I mean, we hear that every single day. But the people that are sitting there in the laboratory doing the assays and behind their computers modeling and coming up with clinical trials designs, they don't get to see it. They don't feel it on a day-to-day way the way we do, but yet they're just as passionate and motivated as the clinicians that are here. So I'm going to say that's really important. That's patient input at a different level. The
At a
work
different level
matters.
I
right?
would say too that there are, even though this data is very scarce, because I think that patient incorporation and the incorporation of lived experience at this level feels like it's a paradigm shift. So there's not a lot of older research on the way that interdisciplinary teams can impact quality of research, but there is some. And there's a study that shows that when you incorporate patient input from the beginning, the research questions are judged more accurate broadly in terms of the outcomes that matter most to patients. You can also see that when you have patient input from the beginning, that retention in studies is better. So there is some data too, some hard data if you're applying for a grant and you'd like to justify why you need like the funding for somebody with lived experience. You can find that data that says that it will actually improve your research in these very concrete ways that go beyond ethical. And I think part of the reason why I keep stressing that is not that ethics isn't important. To me, ethics is the important thing. However, I think when a lot of people say, I'm including patients because it's the right thing to do, they feel quite satisfied with a minimum of engagement. They believe if they've seen the patient or listened to the patient, then they've done a good thing and that's enough. And I think that that's why my tendency is to focus more on the effect on outcomes, because it's not just how things look, it's how things are. And I do think that that is some of the mistakes I've seen some of the earlier Recover researchers make was more in that field of, well, what do you mean we're not incorporating patient input? We have a patient committee. That's true that there is a patient committee, but it's not particularly helpful if that is encapsulated in a bubble and the information never actually reaches the higher echelons of study design.
Right.
So I think that's a very important aspect that I would love to stress.
No, I appreciate that. And the other thing that's come out in, I think particularly with long COVID, but before with your group and others, is so many patients were scientific experts before they became ill. And first, I can't imagine the frustration of watching with a deep personal need, people bumbling around doing the wrong things when you know from your own expertise that it could have been done better. But also engaging, I mean, what we found with that paper you referred to, the Lancet paper, that was, those were some kick-ass scientists in that working group, all of them patients who
Yes.
were frustrated because there was no funding, no way to do it. But damn it, how many people were in there? That was a survey-based study that surveyed thousands of patients and their experiences, their lived experiences, their presentations, and it taught us some important things. Long COVID doesn't have to immediately follow your COVID. No one would have
Right.
thought that. The original case definition said you never got better from your COVID, right? Most of them said that
Yes.
actually. But in fact, the lived experience was, I thought I recovered, but then I crashed and I never recovered from that.
I
That was,
just talked about that in a meeting right before this one. It was very interesting. There's this classic 2 to 3 month gap that many, not all, but many people experience between the acute COVID infection and the onset of long COVID symptoms. And the reason that I started talking about it was that somebody asked me, how many people do you believe got ME/CFS from some infection or immune perturbation that wasn't COVID from 2020 on? And I had to say I would have no way of ever proving anything about that because nearly everyone has had COVID. And you can't simply judge because someone wasn't sick directly after their COVID infection that COVID wasn't their trigger. We are in a no man's land in terms of the only samples that we have that we can really count on being not COVID influenced are banked samples from 2019 and earlier.
mhm.
Um, Everybody has had COVID or nearly.
So you hear that, y'all, that those freezers, don't ever let the power go out.
Don't ever let the power go out. I'd
But
be
what I was
happy.
gonna say, Jamie, also about that, I'm sorry, just to
No, no, go for it.
speak on top of you, but that same but I guess people call it qualitative research when you have the lived experience and you find different ways to turn that into data and turn that into knowledge you can share. But I think
Absolutely.
that is so important, and we don't do enough of it. In our long COVID study with the CDC, we were having tremendous trouble getting people into the study, even though there's a vast number of people. It's a South Florida study. We had to recruit from hospital-based systems and healthcare systems. We weren't allowed to just go put a billboard up, try to recruit. But nonetheless, we really had trouble engaging people, and we did a qualitative study to talk about why that would be. And of course, we were also really shooting for a broad demographic from the community.
Mhm.
And our clinics tend to get people who know how to obtain specialized healthcare. That's very,
Right.
very different demographic than necessarily what actually resides here. And and anyway, we learned a lot, and we learned a lot. Some of it was just what you're saying, accessibility. What time can we come in? Can we make Saturday hours? things like that. Of course, for us, it's languages and having people who are native using the languages correctly.
Mhm.
South Florida, I think 55% of our cohort is, Spanish is their first language. And so it mattered a lot who we even had as our coordinators and so on. And we found the same thing with our veteran studies. When we have veteran coordinators, we're far more successful at recruitment and retention. That
Yes.
no matter how passionate we are and how convincing you can be, if you're not a veteran, you haven't lived the experience, it really matters to have, at least on the recruitment side, people that have lived the experience to talk about why the study is important and why it might move the needle.
Right. And I think that I feel like that's step number two. Step number one is just having the committee and saying nothing. Step number two is asking for help with dissemination, like we already did the study or we're already recruiting for the study. Please share it with your community. And then after that, I would say like actually having patients involved in outreach strategy. And all of those are good things. And yet, uh, having somebody with lived experience on your research team in a more consistent way over time is just going to make it so much easier. There's a question in the chat. Haven't found a lot of engagement on the topic of long COVID MECFS it says in the Nordics. Do you mean like Norway, Finland, Sweden kind of area? Okay. So I actually do know some people who are potentially building a long COVID clinic in that area. I don't think that they're at the point where they're Norway. Okay. I don't think they're quite at the point where they are seeking patient input yet, but I will definitely be talking about that in the future. I would say that one of the most common requests for longer term engagement these days that I get is somebody asking me to help them set up their clinic. And I have not been, that's not a request I've only received from people in the US. The problem is always funding. I think that people reach out to nonprofit organizations in hopes that they will get long-term help for free. So I'm always happy to talk to somebody for an hour, like about an issue that they have, but ongoing help. My work does have to be paid for somehow because we are a nonprofit organization that has to keep the lights on and the doors open. So we have to find some way to pay for my time. So I will always put information out about those kinds of things. I'll go ahead and I will drop the Emmy Action mailing list into the chat so that as new information about these kinds of things comes to light, you'll hear about it from us.
That's great. You are the first time we've had a patient advocate talk to our research seminar, so I'm sure my folks are scratching their heads trying to understand this from their own perspectives. I wonder if anybody else would like to speak up about how they feel about engaging patients as they develop their research studies and their research plans.
You guys can also talk hard science to me. I taught organic chemistry and I worked at the Stanford Genome Technology Center for a year and a half on this disease. It just ends up being that it tends to be that people have trouble recognizing dual roles. That's also like a pitfall you can fall into. Nancy said how interesting it is that so many people with lived experience also have science backgrounds. I remember going to a conference and, going for my little name tag that they give you. And they had two piles and they said, "So are you a researcher or are you a patient?" And I was like, yes.
Don't you hate that? But I had
Yeah.
a great experience. I went to a friend of mine that's a murder mystery writer, and I went to a
Ooh.
conference, and they gave different tags to Keller's tags to people who were published and people who
Huh.
were unpublished. So they asked me where was I published, and yeah, sure, I've written some MECFS books, not murder mysteries. But I
That's
went
really
with a
funny.
published name tag, and all these people kept following me around trying to get my advice. I'm like, this is fun.
Yeah, that's I do write fiction in my other life. I just don't really talk about that in this context. But yeah, I do write fiction too. It's not usually murder mysteries though.
That
That's
was a lot of
that's
fun. I enjoyed
yeah,
that, but
that's something completely different. But does anybody have any other questions about long COVID, ME/CFS, patient perspective, how to incorporate patient input into your studies?
what
Um,
kind of studies do you think we should be comparing the two in? What is the, you know,
so there
where does
are
it overlap? How do, and also from the point of view of grantsmanship, is it to our advantage to be considering our studies ME/CFS with a long COVID comparator group? Or is it to our advantage to be considering them long COVID with an ME/CFS comparator group? Whose study section do we send them to?
these are all great questions. So there are a couple of concerns with the overlap question. So the way that I think most people who study these diseases are currently conceptualizing it is that multiple pathogens and immune perturbations can lead to an ME/CFS-like picture. So while there are people who favor the explanation that there's actually a latent virus that's reactivating when you get hit with COVID, a latent virus that's reactivating when you get in a car accident, or what have you. But for whatever reason, they've chosen a very particular pathogen that they think is the source of all pathology. So that is a school of thought. And I do think, however, that the prevalent view with people who have been studying this class of diseases before 2020 is that multiple different pathogens can initiate the pathology. So if that's the case, then when you think about long COVID and you think about ME/CFS, you would say, well, long COVID is long-term sequelae that develop after a SARS-CoV-2 infection, and that might be ME/CFS. It might be POTS. It might be that your collagen disorder that you have from your genes, but maybe it was very minor presenting beforehand, gets worse or noticeable for the first time ever, or you develop mast cell activation disorder, or PANS and PANDAS, and so on and so forth. So the problem with overlap is that a lot of people will say, well, we're going to compare long COVID and ME/CFS. Except if that's the case, you've compared long COVID, which is, maybe 5 different syndromic disorders, to one of those syndromic disorders. So you're comparing a pot with A, B, C, and D to D. And all of my data people are already beginning to process why this might be a problem. You really want to avoid doing that. Or if you do, you want to be extremely explicit about what you're doing and why it's still a good method. The other problem with long COVID versus ME/CFS is that ME/CFS takes quite a long time to diagnose on average. So therefore, most of your ME/CFS patients have been sick for 3 years or more. I think that is a really safe thing to say. However, all of your long COVID people who have been sick for 4 years or less. There is a somewhat seminal study by Mady Hornig and other Columbia University folks that showed that the immune profile of early ME/CFS differs quite a bit from that of late ME/CFS. And everybody who studies immunology has found immune excitation very early in the disease and some signs of immune exhaustion later on. I think that that's a generally safe thing to say is the case. So if you aren't careful, you could be comparing early ME/CFS to late ME/CFS and calling it long COVID versus ME. So and this is something that, again, like folks who've been researching this a long time would probably be nodding along with me. People who are a little new, that might be surprising. But for those of you on the call who have immunology or metabolomics or background that's kind of more systems based, you're probably thinking to yourself, yes, of course, in the beginning, there's this acute infection or acute immune perturbation. Probably all the body's defenses are up. And the immune system is trying to kill the pathogen with everything that it has. And then later on, you see low function of natural killer cells. You see a lot of naive B and T cells because the B and T cells are, well, you know what, that I'm going to stop because I'm hypothesizing like why that's true. That's one step away
It is
from our data.
true.
It is true, but
Yeah,
we don't want to
it
say
is.
why necessarily, but we will say that that's often conceived as part of an immune exhaustion picture. So you do want to be careful of comparing those two. For grantsmanship, I would say it depends on which institute you're applying to. I think NINDS in particular is going to be like, ooh, an MECFS study that happens to also consider long COVID. Other institutes, probably less so. It also depends if you hear from an institute when you talk to their program officer, like we've had it up to here with the long COVID stuff lately, putting a new spin on it by focusing on MECFS might be effective. So I still do really think it depends on which institute you're applying to. They all feel very differently about things. Okay, what about comparing long COVID that meets criteria for MECFS, including PEM, to MECFS? So that is our, what if you're just comparing early MECFS to
Sorry,
late?
I put that in right before you said that.
Okay, okay,
And then,
okay.
yeah.
Yes, I do think a lot of people would consider that to be like an interesting like comparison study anyway, provided you made it very clear that, you know, the median time to onset for our long COVID group is 1.8 years. And that might be more interesting. Okay, and then I see, how can you tell the difference between long COVID and CFS with all the overlap? Well, so I would say that long COVID is, again, a term that applies to any sequelae after SARS-CoV-2 infection. And that I've been talking about syndromic conditions, conditions that are identified by their symptom set. But, you know, you do also have things that happen after COVID, like kidney damage long-term, lung fibrosis long-term, things that are not necessarily syndromic, and they're still under the long COVID umbrella. So when we talk about how do we tell what is MECFS, we would use the diagnostic criteria for MECFS. The one that's most used in studies is the Canadian consensus or international consensus, and then the 2015 IOM. The 2015 IOM criteria requires post-exertional malaise, long-term fatigue that significantly inhibits what you're able to do, and then cognitive dysfunction and or orthostatic intolerance. So it is pretty particular, and you do need to check all the boxes to meet the diagnosis. And I would say that if somebody with long COVID checks all those boxes, we would say they have the MECFS picture. And we would say that from a clinical perspective, it's appropriate to give them both ICD codes so that they can access whatever interventions, whatever disability accommodations that they need, or that will be best for them. And I would say the same thing for POTS. You would say you developed POTS after SARS-CoV-2, therefore you have the long COVID label and you have the POTS label. And if the question, okay, next question. In your opinion, what is the accepted view or views about the causes of long COVID and MECFS and how they might relate? So I think that we talked about the viral persistence thing as an idea. That's very popular with the long COVID folks. I think it's less popular with the MECFS folks, although there are people who subscribe to that idea of pathology. And I think the MECFS folks have seen very similar presentation develop as the result of a number of different documented infections. So that changes our perspective a little bit. And I conceptualize it as there being three buckets from which pathology arises. The first is the damage that the acute infection did, that lung fibrosis, kidney damage, liver damage, that kind of stuff. You do have to address that. In a clinical context and in a research context, you do have to consider that some of your symptoms might be arising from that pathology. The second one is viral persistence, viral fragments hanging around, or co-infections that are present because the immune system is a little crapped out. If that's going on, you do have to address that from a clinical context, and you have to consider that that might be where some of your symptoms are coming from in a research context. And then the last bucket is the immune, endocrine, and metabolic shifts that occur as a result of that hard hit. I really do conceptualize that as being where a lot of our symptoms come from. And those symptoms may or may not mitigate or disappear if you deal with the first two buckets. I don't think it's necessarily reasonable to say that those changes will disappear if you remove the effect of the initial insult. And I think you guys heard what my master's degree is, clinical alternative medicine. It is very, how should I say, linear to suppose that every impact on the body can be reversed if you find the right single chemical to apply. It may be that those changes are not unable to be mitigated or anything, but I don't think you can turn back time on that third bucket, at least not with our current clinical understanding and tools. I do think that there are I think a lot of the most promising medications are affecting that third bucket, though. I think that that's where a lot of the effective therapeutics are going to come from. Okay. And someone asked for oh yeah, the Lancet paper, not mine. I was not on that one. I will, however, put the
I just stuck it in there.
yes, I'll put the
Yeah.
clinical review though. That's the one that I was talking about that I had
Right.
written. Co-authored, of course.
Sure.
Yes.
Well, you're on the subject of comparing long COVID to ME/CFS. As just as someone who tries to design studies, what are we going to do now to be able to compare ME to CFS if the onset was after 2020?
I think we've never really been able to look at onset in this disease. I think that the long COVID studies are a way that we've looked at single pathogen initiation. And then there's that one Lenny Jason EBV study in college students. That's like this number of people developed.
The Dubbo study, the Australia study.
Oh, that's true. That's true. That's true. Okay.
That was prospective. Says the only two studies I know, three, because one was Lenny Jason's with the EBV, right? And there was the Australia study, which was Andrew Lloyd's study and group that followed post-EBV, post-Ross River virus, post-Q fever. And then there was one by White, the first one ever, was a psychiatrist in England. I forget.
Oh, yes, Peter White.
Peter, yeah.
There was a SARS-1. There were two SARS-1 ME/CFS studies, very tiny.
But wasn't the Recovery Network gathering people from acute infection? So they should have a fairly large cohort by now of people that they actually enrolled during acute infection to follow longitudinally. So that'll be another one. But anyway, there was a study by the CDC that came out about 2 months ago that was prospective to look at the incidence of long COVID/ME COVID after acute infection. And they followed people with a documented infection of COVID or a documented infection of flu or something else.
I remember this study.
Yeah.
It had some flaws.
Of course, but it also was prospective and caught people at the time of the acute infection. And they said that the risk was about 4% of people would still be sick. I don't remember, it was 6 months or a year later.
I think it was 6 months, but I could be confusing it for another study. So many people have done the 6 months thing, which for people on the call,
that the rate was the same, right?
Yeah, but okay. So first of all, that determines I think when you say the rate was the same, I think you have to clarify for our audience the rate of what and what, so that they fully understand.
The rate of ME/CFS-like illness at 6 months post-acute infection.
Oh, okay. So I thought you were talking about a study, and I believe it is the same one, that was talking about whether like ME/CFS incidence in the post-acute COVID group and ME/CFS incidence in a non in a group for whom they had not proved that they had acute COVID. So like, this is the rub. The testing is not always accurate. People are not always testing. People don't always make antibodies. So when they're like, oh yeah, we have a group of COVID naive, like immunological systems, I'm like, I don't think that's true. I'm sure all those people also had COVID at some point. So that was part of the reason why I thought that study was not so great. And I mean, of course, my bias would be to say that there might be something wrong with that. But I think that there's another interpretation, supposing that mystically they really were able to get these unicorns who all never had COVID, which would be to say that either they had a slower onset or they were initiated by some other pathogen or some other immunological perturbation. I think that all of that is certainly possible / probable. And the idea is that ME/CFS can be initiated in susceptible people by any immunological perturbation of sufficient, I don't want to say trauma because that always makes people think of emotional trauma, but immunological trauma is probably technically the right thing to say. I did think that study was quite puzzling. And I wondered why they had done that, or what was their conclusion that they wanted the reader to reach. My guess is that the conclusion that they wanted us to reach is that ME/CFS isn't ever associated with infection. I think that's a hard sell at this point. There's so much data on the other side that at this point you'd say they made a mistake in their study design rather than, yes, it must be true that it is not ever kicked off by infection, or if it is, it's just as likely to be kicked off by anything else. That doesn't seem very plausible. And I know some of the authors on that paper, so, you can always ask them.
Yeah. I was trying to pull it up, but I can't find it very quickly.
How severe
Right.
were the symptoms in the outcomes? I think I need a little bit of clarification on that one. What
Sorry.
symptoms?
I'm just wondering, I mean, it looks like Nancy's looking for the paper. I was just wondering, like, like you said, the outcomes were ME/CFS like illness, like how severe, like how disabled were they? Were they like, like I was just looking for clarity in terms of how significant those fatigue symptoms were, if they were different across the groups, or like how it was measured.
Okay, that's a really good question for the authors of that paper, but I can say in more general ways that the 2015 diagnostic criteria requires that the symptoms be relatively severe in order to reach diagnosis. It's something like they have to be present for this percentage of the time, and your functional capacity has to be decreased by, like, is it 50%, Nancy? Am I remembering that correctly?
That's right. Yeah.
Yeah. So that is in part how you end up with, in addition to having no FDA approved treatments for this disease, that's how you end up with a disease in which 25% of people are housebound or bedbound, and only about 13% can work full time. And with the most severely affected, bedbound, unable to communicate, and really unable to participate in most aspects of everyday life. In fact, one of the things that I think that is very important when we think about endpoints is ensuring that patients with the most severe presentation are really, their change in symptoms is able to be measured by these instruments, as oftentimes they're so severe that they fall off the end of functional capacity scales, and they climb higher than the highest severity level for particular symptoms. You want to say that if a patient is so severe that they're bedbound and they're unable to tolerate voice and human touch, and then you give them a new drug and they're speaking, even if they're still bedbound, like, that's a huge deal. And you want an instrument that's going to be able to measure that change in functional capacity. That's a big difference for people. but most instruments won't capture it. There's one functional capacity instrument created for long COVID called the FunCap, and a lot of people really like it. So I think that that's a good way to measure severity as well.
And the FunCap is special because it really tries to assess the severity of illness after an effort.
Yes.
Whereas the others are, how do you feel today, right now, in this moment in time? And this one says, if you went shopping today, how would you feel tomorrow? That kind of, yeah.
That is a really key aspect of this disease, and it is I call PEM the pathognomonic symptom or pathology, because we see some similar presentation in inborn errors of metabolism, but generally speaking, we don't see that dramatic downturn after an effort, often but not always with this characteristic kind of circadian delay. Like, people will often experience that downturn of their symptoms exactly 24 hours after the effort. And that's odd. It's odd enough that you would really think it would have been recognized as interesting or unique far before it has been.
Yeah, and teaching about this illness to providers, it's the most important point to get across. And you can usually win the argument with them because the other illnesses they've learned this in are all neuroinflammatory: multiple sclerosis, myasthenia gravis, illnesses with significant neuroinflammation components. So usually I can put that with some PET scans up and I can say, no, just stop talking about this as anything other than a brain disease, a real brain disease with a whole lot of other aspects. But this is, a brain disease.
Yes,
So.
It's at the very least, there are neurological, there's strong neurological symptoms and strong signs of pathology in the central and peripheral nervous system, which is why I think it is quite reasonable to consider it a neurological disease. And that is how it's classified, G93.32 these days. And I would add too that this pattern of an immunological shakeup followed by systemic neurological or neuroimmune, we might say, symptoms is really common in neurological diseases, and we're finding more neurological diseases fit that pattern every day. I talk about Guillain-Barré, and I'm sure I'm saying that incorrectly because I've never heard anybody but me say it aloud. However, I consider it to be like ME/CFS's evil older cousin. It has a lot of the same symptoms, but changes are typically progressive, and people do die from it. And it has the same pattern of often being kicked off by an acute infection, but sometimes being kicked off by a car accident, a pregnancy, anything else that dramatically, thank you. Somebody said I said it right. I appreciate you. So we see that in Guillain-Barré. And then we now have quite a bit of solid evidence that multiple sclerosis is often, if not always, kicked off by Epstein-Barr viral infection. We have Alzheimer's being associated with infectious onset. We have, and it begins to become clear, at least for those of us who have interest in ME/CFS and have observed this pattern in ME/CFS, that this may be possibly not universal, but a very common pattern in neurological disease onset, often coupled with a genetic susceptibility as well. And I should say I'm quite interested in that because I have it, my mom, my older sister's daughter, and now my first cousin have all been diagnosed with ME/CFS, long COVID, or both. So it runs pretty strongly in my family.
Well, I appreciate your mentioning that because in Gulf War illness, another illness that we're interested in that presents with post-exertional malaise and all the other features of this illness and these illnesses, I should say, but it's a toxic exposure rather than a viral hit, but a neurotoxic exposure. They do have a genetic predisposition, and it is actually the gene that regulates the rate of detoxification of organophosphates and diesel and gasoline and other types of organic fumes. So that's interesting.
I mean, I think if people are exposed to organophosphates or other neurotoxic poisonous chemicals, if they weren't exposed to those chemicals in the field of war, they often get the ME/CFS diagnosis because of the symptom presentation being so similar.
Or it's actually how veterans get disability. There's no disability for Gulf War illness, but there is for ME/CFS.
And this is how we end up in this fun diagnostic dance for eternity, and
And fibromyalgia.
dividing all of this up in tinier and tinier pieces. Some of the most interesting work I've seen lately is that the new fibromyalgia criteria, which someone just mentioned in the chat, fibro, and the new EDS criteria, it's all like these gigantic vines, and they're all growing together to eventually be very similar criteria to each other. As people begin to realize, I think, that the symptom presentation really, like people who have fibro often have ME/CFS or the reverse. People who have ME/CFS are often hypermobile. So when you try to tease out, well, what symptoms and pathology are really due to a connective tissue problem, it's very hard to get a patient who has one without the other. And you end up conflating, well, two perspectives. You end up conflating different diseases because they're such common comorbidities with each other, or you simply cannot. They're either very similar or you cannot separate them in a nutshell. And this was a problem that NIH study by Avi Nath had, where he was attempting to find a pure ME/CFS with no comorbidities. And in so doing, you end up with a very irregular, unusual patient. I believe something like 80% of people with a diagnosis of ME/CFS have at least one other diagnosed condition. And that's not how many conditions they're living with. That's simply over the diagnostic journey, they've been given more than one label.
Or they developed more and more things because of their vulnerability from the first thing.
Oh, absolutely.
So with
Yes.
Avi Nath's study, we're doing a study with him now with the Gulf War guys, same exact protocol, right? To have some comparable things. And
It's worrying though.
so we
There's
had to really
220
argue
in
about
it.
comorbidity because it's 33 years after these guys' exposure. They're 33 years into an illness. And they have all kinds of comorbidities. And if you want to be able to generalize the results, you have to take the patients you have, not the ones that are
Right.
super clean.
That I would agree with you with. That study started off with hundreds of people, at the first gate of should they be allowed into the study, and ended with 17 because so many people were eliminated from it. I agree with you that you actually have to look at everybody together. After all, if you are attempting to characterize a disease, you need as many people as meet the diagnostic criteria for that disease without being able to explain it with other diagnoses, and put them in the same bucket so that you can see what it is that they have in common. I think attempting to find a pure ME/CFS patient ended up with a cohort that was very unusual, and not necessarily representative of the population. And I recognize that I'm talking from a study design perspective that's more syndromic and might even be applied to like a group of people with depression, possibly, because we're trying to look at something that does not have a biomarker, something that is identified by its symptom sets, and we want to determine what drugs or interventions or pathology we can apply to that group. So that's my little soapbox on that one. I would rather have a really big complex group and start dealing with that group as a complex reality. I think we can't break it down too much without losing the nature of the group.
Great. Well, I think that I appreciate that. And as long as we got you on the nature of groups, let's talk about lumpers and splitters for a moment, because you can imagine that there's a call for both, as you just said, that when you're like, if I'm doing a COVID monoclonal, it would be ridiculous to include an ME/CFS pre-2020 cohort in there because presumably
Yes.
that's not COVID. But here's what I'm saying. Then right now there's been a big press politically because of funding
Mhm.
to lump post-infectious illness together, the post-Lyme, the post ME/CFS patients, the long COVID patients. It leaves out the environmentally ill, toxic exposure patients.
Mhm.
And I'm wondering, what do you think about that?
So, just for the people in the call who might not know, lumpers and splitters refers to the tendency to put as many complex patients kind of in the same categories and research them together, and even believe like the pathology is essentially the same. And splitters are people who are more particular in terms of like they are dividing infection associated chronic conditions into and I think it's fair to say dozens of categories. So I don't think it will surprise anybody to know that I am going to golden mean this and say that the middle of lumpers and splitters is kind of where I live. I think that infection associated chronic illness, which to be clear, by the way, should include people with exposures because infection associated means the disease is associated with infection. And it is because up to 80% of people with ME/CFS report an infectious onset. It does not mean that every case must be kicked off by infection. We've mentioned multiple times throughout this call that car accidents like physical trauma, pregnancy, and other things that affect immune function or neurological function can kick off ME/CFS. So there's probably not going to be a name ever for these diseases that is satisfying to everyone, but I think it's fair to say that the disease entity is associated with infection. So I would say, though, that whether I'm a lumper or a splitter relies to some degree on whether we're looking at a research study or clinical care. When we're looking at clinical care, I'm often a lumper because what we are looking at is the end symptoms. And I think in that case, infection associated chronic illness should have a shareable bucket of interventions because if you have orthostatic intolerance, which is part of the ME/CFS criteria, you should be able to access that intervention, whether your label is ME/CFS or POTS. However, when it comes to research, I think that we should be a little bit more discerning because we're often attempting to determine the pathophysiology, like what is it that is actually causing the problem, and perhaps we need more diverse cohorts and less diverse cohorts in order to really understand the full picture of how related the pathology is disease to disease. I think, though, that from my perspective, as somebody who does a lot of patient outreach, epidemiology, the label that someone gets is largely associated with their race, their gender, their nationality, their part of the country in the United States, and which specialist they saw first. So we have to remember, and this is probably going to be the last thing that I'm going to say, but it's a good thing to go out on. When you're looking at EHR data and you're looking at clinical data, you are not examining pathology. You are looking at the clinician's opinion or point of view. I wish I could blast that from the rooftops because I feel like Recover in particular has leaned on EHR rather a lot. And it's not always as useful as it might be. I understand it's a gigantic data set and that is extremely appealing. But whether somebody gets the long COVID label depends on their socioeconomic status and their luck and where they live and if they saw the right doctor, and whether you got a label of POTS or ME/CFS depends on similar things. If you have similar symptoms, there's definitely orthostatic intolerance without PEM. So POTS, I would say is, to me, the orthostatic intolerance without the PEM necessarily, without the other ME/CFS symptoms per se. But there are certainly a lot of people who are walking around with a label of POTS who do have PEM and qualify for diagnosis of ME/CFS and have never received it. and therefore aren't necessarily getting the pacing advice. They're talking to their POTS doctor who's telling them, I understand exercise is hard for you, just try it lying down. And so in that case, for clinical care, the splitter point of view matters, but the label does not matter as much as people think it does, because the label is extraordinarily arbitrary.
At least for searching data sets, but
Yes, for searching data sets.
because the paper by Lenny Jason, it was done in, probably 12 years ago, but still, just demonstrated that the only people that know how to diagnose ME/CFS are people that have it in their family or among their friends. It doesn't matter what their specialty is. It doesn't matter how old they are, how young they are. But I'm going to have one hopeful comment on that, Jamie, about diagnostics and
I feel like it's changing.
Now, I'm going to say this. I presented a case to an AI engine that had been misdiagnosed by 16 physicians because she was Black, she was young, she had a family history of lupus, but she was an ME/CFS patient. And I presented to an AI engine and it got it right the first time. So my thought was, okay, if AI engines are going to not know the color of your skin, they're not going to have all the societal biases. All that's not going to be there. So
I think they're going to have the societal biases because AI is taking the information from the.
Yeah, but not as case by case is, I guess, what I'm trying to say.
Yes,
there will be biases because there's bad literature and it's pulling it mostly from the literature, but still, I just was encouraged because I have spent the solid 35, 40 years of my life trying to convince other doctors that this is a real deal, take it seriously and take good care of these people. And I just am astounded that I'm still sitting in clinic today having patients tell me the same dreadful stories they told me in 1990.
That's because people and their nature, I think, does not change. And when people don't understand something, their goal is to, their psychological goal is to protect themselves from feeling bad about themselves. So they're going to say it's the patient's fault, that they don't know what's going on, that the clinician doesn't know what's going on.
Doctors don't know how to say, I don't know, which is on us to be able to teach our medical students that it's okay to say, I don't know. But
it is okay.
The worst thing you can say is, I know everything and I don't know, and because I know everything and I don't know what you have, it must not be real. Which is the logic.
I know everything worth knowing, and if I don't know it, it must not be very important. Which I hear that gist sometimes. The last thing I would say before I scoot is that the AI thing proves that the good data is out there, which is wonderful news that it's actually there for people who want to look at it and want to understand. And that the best thing that you can do to educate people is to share good information from a public relations advocacy point of view. If you say something like this disease is real, you can end up highlighting the fact that other people disagree. But if you say something like, this is a pretty serious chronic neurological problem, like here's this paper, it's really good, that then people are going to be like, oh, I guess I have to learn about it. Which I know nobody likes the idea that there's something they don't know and they have to absorb new things. We're constantly being inundated by new information. But simply presenting good information is often much better than discussing the mistakes of the past in terms of getting new people to absorb the information. I think that's my final word for today. Thanks everybody for listening. Feel free to reach out to me. Since my PowerPoint is down, I will just go ahead and put my my email in the chat. Anybody who wants to come and chat with me or send me a message is welcome to.
Well, we'll let you go. I know we went over our time, but it was because everyone's so engaged in your conversation. So thank you.
All right. Thanks, everybody. Have a great weekend.
Jamie. I appreciate you.
Be well. Bye-bye.